Good afternoon and welcome. Thank you for joining today's webcast to celebrate the 3rd Annual Health Quality Council of Alberta's Patient Experience Award recipients who are with us today. My name is Marie Owen and I am a member of the HQCA Board of Directors. It is my pleasure, truly my pleasure, to be here today to serve as moderator for this webcast. For everyone on social media, our hashtag for today is hashtag PXAwards18. For those of you who don't know, the Health Quality Council of Alberta, also known as HQCA, is a provincial agency that works very hard to improve the quality of our health care here in Alberta. The HQCA does this by gathering and analyzing data, a lot of data and information, and then sharing those results and insights with the people that can really make a difference to improve the quality of the services of our healthcare system. So how does the HQCA know if quality of healthcare is improving? Well, one very important aspect of measuring or assessing the quality is the patient experience, which is why we're all here today. Being healthy, getting better, living with illness and disability, and end-of-life care are incredibly important aspects of our healthcare journey. However, the results or the outcome of that care is really only one piece of the quality puzzle. As a patient, how do you feel when you are treated as an equal member of your healthcare team? When your doctor considers your perspective and your values when he's creating your care plan? When a caregiver turns to your worried family member and acknowledges that they too have needs? These moments, when the relationship between patient, family, and care provider results in a positive healthcare experience, are really profound and need to be celebrated. This is why the HQCA and the HQCA Patient and Family Advisory Committee created this awards program to take the time for this webcast so that we can hear about and celebrate the meaningful work being done for our patients. But before we hear from this year's recipients, I want to invite Geraldine Leroux, who is a patient advisor on the HQCA's Patient and Family Advisory Committee, as well as a former chair, to come up and say a few words. Geraldine?
Thank you, Marie. I'm very proud to be here today as a member of the HQCA's Patient Family Advisory Committee and to welcome and thank our award recipients. I am a mother, a wife, a grandmother, a caregiver for an aging parent and a younger brother, and a patient myself. The quality of our healthcare system matters a lot to me. What you and your teams do matter a lot. It's not just why I dedicate my time to improving this system as a patient advisor. It's why I work bringing awareness to my family, my friends, and my community about how they can be active partners in their own care. I encourage them to speak up and to share their experiences because each voice on a care team matters and can inform decisions and inspire change. For example, I am currently a caregiver for my aging mother with dementia, and she receives care in Alberta's continuing care system. In this role, I've had many experiences with our healthcare system, and if there's one thing I've learned, it's that relationships are foundation of quality healthcare and positive patient experience. There was an instance when my mother was being moved to a new care facility that I was reminded of this. During my mother's transition, she became less responsive and was not herself. I assumed this was because of the move and her dementia. The staff at the new facility did not have an existing relationship with my mother. They had no frame of reference for the changes I was observing. So I felt a lot of responsibility to help my mother through this. One day, she actually looked gray, and the facility called the emergency medical services. When the paramedics arrived, they assessed the situation and were not sure if her condition warranted a trip to the hospital. She had an appointment with her family doctor that afternoon. Maybe it was better just to wait. As the caregiver and advocate, I wasn't sure. I overheard that her blood sugar level was 26. I knew this was high, but I don't have a medical background. And so I wasn't sure how critical this was. There was a licensed practical nurse, or an LPN there, who was working with the paramedics and I to make a decision. I remember how calm she was. She asked clear, straightforward questions. One question in particular was the game changer for me, and it stuck with me. She asked the paramedics very simply, if you are not going to take her now, what are you going to do about her high blood glucose level? And just like that, the light bulb went off for me. Sorry. As you can tell, these are very emotional experiences. I made the decision, and my mother was rushed to the hospital, and it turned out that she was in kidney failure. I was very grateful for that question, and the brief moment this LPN established a critical relationship with me and my family. She helped make a critical decision, impacted my mother's well-being. She gave me confidence in myself as my mother's advocate, and as a part of my mother's ongoing care team, and as a part of my mother's ongoing care team. And to this day, she's the one at that facility that I turn to. Because of this LPN's approach, I considered the experience a positive one. Even though I have tears about it, it was a positive experience in which an amazing result happened. And as a family, we now have had 2 more years with my mother. This is what each of you do every day with your teams on a daily basis, whether over time or in a split-second moment. You are establishing relationships and creating an opportunity for meaningful dialogue with patients and their family members and their providers. So thank you. Thank you for learning to listen and to care about the patient perspective and their experience. You are making a huge difference, and I'm very grateful for this opportunity to celebrate your success. Thank you.
Thank you. Thanks very much, Carolyn. Those are never easy to tell, but they are so compelling. It reminds us of why we're in this business and the reason that we're here. So thanks so much. We are now going to have an opportunity to hear from this year's 4 recipients in no particular order. Each one will share a 10-minute presentation, and then after all 4 presentations are completed, there'll be time for questions for our recipients. Please submit your questions along with the name of the presenter that you are addressing your question to in the chat area on your webcast screen. Please do this at any time during the presentations while the question is fresh in your mind. You do not have to wait until the end of the presentation is over to submit your question. It is now my pleasure to introduce our first presenter, Dr. Sarah Davison, who is a professor of medicine and director of the Kidney Supportive Care Research Group at the University of Alberta in Edmonton. Sarah will be presenting the Alberta Conservative Kidney Management Clinical Pathway. Sarah?
And thank you, Geraldine, for sharing. So I'm Sarah Davison, and I'm here on behalf of the Kidney Supportive Care Research Group and the Northern Alberta Renal Program to share our CKM pathway with you. So we know that in Alberta, our patient population is aging, and we are more likely to develop chronic illnesses like kidney failure. But most of us, or many of us, are going to develop several serious illnesses. And unfortunately, it's patients like that that have numerous chronic illnesses that don't necessarily do well after they start dialysis. However, those patients with lots of illnesses who become quite frail, if they are treated conservatively, can actually do very well without dialysis and live as long, if not longer, with preserved function, quality of life, without the burden associated with dialysis. They have not just better quality of life, they have fewer admissions to hospital and overall can do quite well. Unfortunately, most healthcare providers and patients don't know that this is an option, and therefore they feel they have no other course but to start dialysis. Unfortunately, the solution is not just as simple as to show patients that they have a choice. And this is really illustrated by Bob's case. So Bob was a 78-year-old man who had kidney failure, and he was cared for in our kidney clinics and was very clear about his decision not to start dialysis. But he also had liver failure. He required frequent taps of his belly to drain fluid. Then one day he presented to the emergency room, and he had accumulated fluid in his tummy, causing lots of abdominal pain and shortness of breath. He was admitted to hospital and started urgently on dialysis. So Bob, when we talked to him after, said that he was coerced into starting dialysis because the care team had said the only way to manage his symptoms was to put a shunt in the liver, and they would not do this unless he was on dialysis. So Bob reluctantly agreed. But a week later, he found out that they could not or would not do the shunt. So he was left on dialysis, but having to remain with weekly taps. Not surprisingly, Bob did not do well on dialysis. He had recurrent nausea, vomiting, cramps. He rapidly deteriorated and had substantial post-dialysis fatigue. And so shortly after, about a month after starting dialysis, he decided this was not for him, and he stopped. He went back to the clinic, he was cared for at home, and he died 4 weeks later. So even for patients like Bob, who know what they want, our healthcare system failed him. And I think his experience really highlights our lack of general awareness or coordination of services around a more supportive philosophy of care. So it results in very high rates of hospital admissions and use of these aggressive therapies that are not well aligned with patients' preferences, that provide little, if any, benefit, and in Bob's case, substantial harm. So our challenge was to develop, implement, and evaluate an integrated approach to care for patients like Bob who choose no dialysis. And our real focus is ensuring all their care remains aligned with their preferences, that we decrease their symptom burden in order to optimize their physical function and their quality of life. We want to make sure that patients and families remain satisfied with their care. We want to shift away from unnecessary use of acute care resources to care for patients where they want to be cared for, which is typically at home in their home communities. And we have to stop practicing in silos. We need a shared approach to care, coordinated care. So the solution, our solution, started with really bringing together everybody, all our stakeholders, which started with patients and families and having them work with our frontline staff to identify what were all the barriers, what were the facilitators to optimizing care for our patients. And we did this through a series of highly interactive sessions using world cafes. And through that, we were able to get all the pieces, like the pieces of a jigsaw puzzle, that we were able to put together that built this interactive pathway. And this way, the pathway was truly co-designed by not just patients and their families, but also by all the people involved in their care throughout their illness trajectory. Our pathway really consists of two main components. There is a patient decision aid that allows healthcare providers and patients to actually determine what is the right care for them. Is it dialysis or no dialysis? And then you'll see on the screen there's two portals that the next part is really about integrated communication and care plans that are meant to be individualized. And you can have a healthcare provider portal, but the patient said, we want our own portal to be able to navigate this website ourselves. This is a snapshot of the interactive patient portal. And through this, patients are able to navigate their decision aid if that's where they're still struggling to make the right decision for them. All the educational materials are here, including their symptom management protocols, but they really focus on what can the patients and the family members do at home to manage their own symptoms before they even start medications or in addition to medications. We've got streamlined referrals from home care to home palliative care. It's a matter of, they said, we want to know what do we do in a crisis, who do we call, who do we ask for help, and we leverage provincial support such as EMS, assess, treat, and refer, so if 911 is called, we can keep them at home. So in terms of our success, early success shows a huge increase in the uptake of conservative care because now we have a positive set of treatment options to offer patients. But most importantly, patients are happy with this care and they are staying on the pathway until death, as opposed to patients like Bob crash landing in Emerge and starting dialysis. We're managing their symptoms, but most importantly, our patients are satisfied. We want to make sure patients and families are satisfied that they received the care that was most important to them. And so I'm going to share the story of both Jack and Jody, and his daughter's with us today. Thank you, Jody.
This is the end of someone's life, but he was finishing well, and there was no regret for me. I think of my dad as a courageous, loving man, and I'm so grateful that he let us experience life together right to the very end, and his attitude was one of being positive and of looking at how he could bless somebody else. My dad was diagnosed with kidney disease a good 20 years before he actually died. 5 years ago, he was still on the route of just looking after his kidneys, and then things started to progress. My dad had other challenges. He had fallen, he had had pneumonia, and had been hospitalized. We talked about this conservative management with the doctor, and it seemed like this was the right thing for us, for most of the part. But when my dad would end up in the hospital, we'd often run into physicians who would always talk about the dialysis with him. That was hard. That was hard because you kind of second guess yourself. You know, have I done the right thing for my loved one? Because I'm the support. I want to be this cheerleader in the background saying, you know, like, let's do whatever we can do. But every time I had the doubt in my heart, I would check the conservative kidney management website. It would just kind of stabilize me, and I'd go, okay, this is normal, this is what he's experiencing, check, check, check. Or I would also phone the conservative kidney management team. There is like this multiple staff of professionals, you know, the dietitian, if I had a question, or the pharmacist especially, I leaned upon heavily. And so I would often go over these things with them. My dad's last stint in the hospital, he had fallen and broken his hip. We were aware that there were other people on that ward that were actually going down and getting their dialysis done. And my dad was just like, oh, you know, I'm glad it's them and not me. I'm ready to go. Like, you know, you don't have to try to keep me here forever and ever. He didn't hold back from much, you know. His life was full and complete, and that's what we wanted for him, was a full life.
So now our work is going to extend to patients with other chronic illnesses. So most of us are going to die with heart, lung, liver, kidney failure, or cancer. And like Bob, many of us will have more than one health issue. So we are adapting this pathway to meet the needs of patients with all these other chronic illnesses, realizing that they share many of the same elements of care, but will require some specialized decision making and some specialized symptom and medical management. And then we will be implementing this at the level of primary care across the province to enhance both patient and community capacity. And I really want to extend a huge thanks, firstly, to our patients, who are, without a doubt, our greatest teachers, and then to the tremendous group of people I work with, including the Kidney Supportive Care Research Group. So Vanessa Stanke, our Senior Project Manager, who's here today, and Jody, who you just heard from, one of our patient partners, and all the amazing frontline staff in all of our kidney clinics in the Northern Alberta Renal Program, who really brought this pathway to life and made it a reality for our patients. Thank you.
Thanks very much, Sarah. A number of years ago, I was director of nursing in a small rural facility, and we lobbied for and got a satellite dialysis unit. And you know, I got to know several people with chronic kidney disease and to better understand the challenges they face every day to manage their illness. And so to have a tool like this to think about their ongoing care is just such a gift, so well done. It is now my pleasure to introduce to you our next presenter, Ellen Charge, who is a community paramedic with the City Centre team. Ellen will be presenting on the City Centre team's mobile paramedic program. Ellen?
Thank you, Marie. My name is Ellen Charge, and I'm one of the founding members of the Community Paramedic Program City Centre team. Our team has been in operation for just over 2 years, and I've been there since the beginning. We have a small team of 5 people, with 2 people working in what we lovingly call the Ativan at any one time. The Community Paramedic Program City Centre team is basically a mobile, non-urgent healthcare team that brings basic medical care to homeless and vulnerable individuals around the city of Calgary. Our team's work was made possible with grant funding from AHS Addictions and Mental Health as part of the response to the report and recommendations made by the Calgary Recovery Services Task Force. This task force was made up of people from various disciplines working with the homeless, and to inform their recommendations, they surveyed over 300 Calgarians living with homelessness. And to inform, at the top of their list of what we need to do to help people living with homelessness was better access to health care. To tell you more about our team and what we have done to address this need, I would like to introduce you to Pops. Pops has been living on the streets in Calgary for the last 15 years, and Pops has never taken advantage of any of the local shelters or food banks or any of the other myriad services available to vulnerable Calgarians. And in his time on the street, he has built up a reputation and a following in the area he inhabits. He is proud to say that he has helped many lost souls learn how to survive on the street, and he feels very protective of many of them. And that is how he got the name of Pops about 10 years ago. Pops is pretty easy to recognize, as he's a familiar face to many who frequent the popular Calgary shopping district. He's really friendly, he loves dogs, and uses puppets that he's created out of stuffed animals to put on a bit of a ventriloquism act to bring in a little money. Because of his protective nature, he would often get in fights and have many open wounds with no way to keep them clean, bandaged, or take medications like antibiotics. He also ended up fracturing his ankle once and never had it set properly, so it bothers him to this day. One of the elders from the Street Outreach and Stabilization team had heard about our team from a presentation, and he called us worried about Pops, his many infections, his rotting teeth, and his ankle. The SOS worker wanted to meet with us first to explain to us what a delicate situation this was. Pops was really not open to help from any medical people, as he had had some horrible experiences in the past and wanted nothing to do with healthcare teams. He was also fearful of people trying to trick him into going to hospital. He was afraid he could not stay very long without going into alcohol withdrawal. He had often told the SOS worker that the only way he was going to hospital was if he was totally unconscious and didn't have a choice. Because of his circumstances, he was suspicious, untrusting, and disconnected. These things had made him, like many of our clients, less likely to access resources even when needed. This often ends up causing unchecked illness progression to where our clients need a longer and more complicated hospital stay. The hospital stay is also complicated by patients going into withdrawal or getting into conflicts with hospital staff due to mental health problems. And when hospitals release people, it usually involves a transition into the care of families and family physicians, support that our clients rarely have. So we were introduced to Pops through the SOS worker. He was suspicious, but because we were with the worker, he was willing to listen to what we had to say. Now, I don't think that we did anything terribly different from any other compassionate healthcare worker, but we were on his turf and we let him call all the shots. We told him what we could do and what we could see that needed to be done, but we listened to him and heard what he was willing to go through and what made him uncomfortable. We let him make all the decisions on his own care, and then we problem solve to find ways to make it work. Because Pops lived on the street and had no way to contact us, we would give him a time frame and he would agree to meet us at a specific location. Over the months, we were able to address some of his medical concerns totally on his terms. First, we were able to get all of his infections under control. We did frequent wound care and made sure that he was taking his antibiotics appropriately. Occasionally, we had to suture up some of his worst cuts and then nurse them through the healing process. We were able to help him with his ankle in a way that was satisfactory to him. As paramedics, our biggest strength is problem solving. So if we couldn't solve his medical problem the traditional way, we would think up alternatives and collaborate with him and our supporting physicians to come up with something that worked. So how does our service accomplish these lofty goals of creating a low-barrier healthcare service for vulnerable persons like Pops? One way that helps improve their basic health care and find ways to connect them to other services for complex care where they are treated with dignity and respect, while also taking into account the complicating factors of addiction and mental illness. First, we're mobile, and we'll go where we're needed. Being paramedics for many years, we're used to working in challenging and uncontrolled conditions. This also provides the option of transporting our clients to appointments when they need someone they trust to advocate for them. Further, this mobility helps to foster relationships with other services that can meet and talk with us rather than just get a phone call or an email, so they end up feeling that they know us and can rely on us when they have challenging clients to find or to help with various problems. Second, we're responsive. We can usually see people the same day, and we work 9 to 9, 7 days a week, 365 days a year. So we are often around when other healthcare services are not. And although we are primarily a professional-to-professional service, we have let people like Pops have our number because he doesn't have a professional around to call for us when he needs us. We don't necessarily give this out all the time, but we've never regretted doing this. Pops is very respectful of our time and talents and only calls on us when he needs us, as he realizes just how many people we are there to help. One of our most useful functions is the ability, with the collaboration of a small group of dedicated physicians, to diagnose and give definitive care in place. So many of our clients refuse to go to hospital and will not follow the rules to get in to see a family physician, or an appointment is made, but because of their circumstances and or their comorbidities of addiction and mental health problems, they will often miss them. The opposite side of this coin is that they will often inappropriately or ineffectively over-rely on emergency or urgent care services. We have the ability to go to them when and where they are, and we arrive with an understanding of their circumstances, some compassion, and a grounding in trauma-informed care. Collaboration is another thing that we do and that really helps our clients. We create relationships with like-minded services so that we know that our clients will continue to get respect and dignity, and when we gain their trust, they know they can trust the people that we refer them to and often transport them to see. What I have found working in this field is that others are as passionate as we are, and when they say they will do something, I know I can trust them to follow through, so I am confident that sending my client to them will be a good thing. We also work with the hospitals and UCCs so that when they have clients that need ongoing IV antibiotic treatment or other treatments that the patients either don't show up for or at all, they can get us involved just by sending a referral through our dispatch center with an idea of where we might find this person, and we're usually able to meet with them to complete a course of treatment. Through these processes, we have been able to connect Pops with a family doctor. We've also been able to take him for specialty appointments. Now we've been able to get him into some stable housing and have helped him to arrange to pay his various fines that he's collected over the years. He really wants to be seen as a member of society, even though he is outside of the mainstream. We also like to follow up with our patients to make sure that their concerns are resolved. We don't just expect that they have taken their antibiotics appropriately or that their wounds have miraculously been taken care of and healed properly. We either make follow-up visits or work with our partners to ensure that their concerns are completely resolved. To this end, we have a very good relationship with the nurses, social workers, and staff at the shelters. And if we need to find someone we have the DOPE team and the bylaw officers that are often able to help us with this. We are persistent in making sure that they get the care and follow-up that they need to stay healthy as long as they want that support. And finally, we're often able to connect them with further supports. We connect them with traditional services and within reason get them to relax the rules a little for our clients. And we liaise often with services that are designed specifically for this population. I wish I could name all of the wonderful people and services that we have found in this city that are nonprofit or city services or AHS services that have created a wonderful network of care for our most vulnerable. It is navigating them all that's difficult, but that is a place that we work hard to be able to help our clients. After a year of our service being available, we did an evaluation to ensure both to ourselves and to AHS who funds us that we are actually making a difference. POPS is one of 365 unique patients that we interacted with in 832 different encounters in our first year. The quote above is from POPS, but the evaluators got many similar ones from our different clients. Even we were heartened when we looked at the number of people we had seen and what many of our clients had said about us and our services. So I think that our statistics show, and we like to believe, that people like POPS now have improved health outcomes and consequently a better quality of life because of our committed and coordinated interdisciplinary team and extensive network of equally caring and committed physicians, social workers, addiction workers, psychologists, psychiatrists, shelter workers, housing agents, etc. The list of people supporting this work, like their compassion, is truly endless. Thank you.
Oh, sorry. Thanks, Helen. You know, for those of us who have spent the bulk of our career within the walls of a hospital, we have no or very little understanding of what the challenges that you go through with dealing with people like POPS. It's incredible what you do, and I love your comments about listening to him and problem solving and, you know, ensuring respect and dignity for people like POPS. So, well done. It is now my pleasure to introduce Navjot Virk and Uzi Bohia from the Brenda Strafford Foundation. Navjot is the Research and Innovative Practice Coordinator, which is a great title, by the way, Navjot. And Uzi is a healthcare aide at the Wentworth Manor Seniors Care Facility. And they're going to present on the Foundation's End-of-Life Framework and Program. Come to the podium.
Thank you very much. So my name is Navjot Virk. I'm the Research and Innovative Practice Coordinator with the Brenda Strafford Foundation.
And my name is Uzi Bohia.
And we are honored to present on behalf of Wentworth Manor and the Brenda Strafford Foundation the End-of-Life Framework and Program that was developed by our care teams. So to begin with, a little bit about us. The Brenda Strafford Foundation has been providing excellence in seniors care for over 40 years. We currently have 4 care homes in Alberta, 3 of which are in Calgary, which are Beauview Manor, Wentworth Manor, and Clifton Manor, and we have 1 in Okotoks, which is Tudor Manor. So when we're looking at our environment, it is a continuing care environment, primarily long-term care and supportive living, and our population and those that we serve are older adults or residents and their families and loved ones. So the challenge, or what we like to term it, is the opportunity for improvement was really identified through satisfaction surveys and focus groups with residents and families. In the last 15 years, as shown in the literature as well as our anecdotal experience, there has been a significant change in responsibility in long-term care and supportive living homes. Most of our residents do live with us right till the end of their life, and the experience can be challenging or complicated, especially for those living with dementia due to the loss of their cognitive abilities. A lot of times decision-making related to care needs often rests with family members, and so we found that there was a unique opportunity to really look at enhancing the capacity and skill set among our employees to address this shift in change, as well as look at our palliative care programs and processes in a holistic lens. And so the way that we did this was really through the feedback that we received through satisfaction surveys and focus groups. But we also did a needs assessment, and this was done in collaboration with the University of Calgary Faculty of Nursing, community practicum students at Wentworth Manor, where they went and asked our residents and families in terms of what they thought would be the most important areas to focus on when enhancing our palliative care program. And so when looking at this program, we really wanted to hear from them. And so a key area that was identified for improvement was by residents and families was looking at relationships and emotional support at the end of life. And in addition to this, employees also had identified that there was a knowledge gap or an opportunity to enhance their knowledge around palliative care processes. So the solution, the very exciting thing about this was that we had the entire interdisciplinary care team come together to hear from what the residents and families were saying and come up with a solution. And so this involved our frontline staff from healthcare aides, LPNs, RNs. We had physicians, recreation therapy staff, pharmacists, as well as leadership support from our medical director, director of nursing, and administrator, who really looked at how we can incorporate what we heard into a framework to enhance the delivery of palliative care to residents and families using a holistic approach. And so I'll outline a couple of the interventions and things that we had implemented, focusing on the domains of physical environment, relationship, and planning and delivery of services. So when we started out the initiative, we really looked at creating a palliative care bullseye framework, and this was by looking at the evidence and what the literature had identified in terms of important domains for palliative care. When we looked at the physical environment, what we heard from our family members was there was an opportunity to promote comfort in the physical environment, and what we introduced were palliative care carts, which are pictured on the slide. The purpose of these palliative care carts are to provide comfort, and they have different items such as refreshments, toiletries, robes, magazines, etc., to be brought right to the bedside of their loved one during this process. When we look at relationships, what we heard from family members was that they would like to have more of an opportunity to learn more about what does end of life look like and the different experiences that their loved one may be going through. And so these family nights were introduced in partnership with residents and families to really enhance the knowledge and support, but also have an opportunity to answer questions that they may have for us. Another tool that was implemented was a brochure, and this brochure was really to highlight tips and techniques of having high quality end-of-life conversations. And so those were the primary elements that were implemented with respect to relationships. And then the last piece was planning and delivery of care services. So we spent a lot of time looking at addressing the knowledge gap among our staff, and this was addressed by having our staff trained through the Pallium LEAP course. We also had our clinical nurse educators provide extensive education and mentorship for our staff. And another large piece of this was looking at ways that we can identify a change in status among residents earlier so that families feel more prepared during the end of life. And this was accomplished by looking at RI data in different scales. I'm going to hand it over to Uzi, who's going to provide a frontline perspective from the healthcare aide point of view.
While planning the palliative care program, the coordinator asked me this question. As a healthcare aide, what can you contribute to improve the quality of life and provide comfort to our residents? I responded by saying, since I have a passion in singing and I love to cheer people up by words of encouragement or a simple smile, I can organize a singing group made up of fellow workers to help bring comfort and peace of mind to the residents and to the family. Healthcare aides are the first line of care. We spend a lot of time caring for them. That they learn to trust us. I have learned in my conversations with them that many are Christians. One of my favorite things to do is to sing their favorite hymns and even request songs to sing, and we believe that music is the language of our soul. Every time we have palliative residents, the singing group will visit and offer songs including their favorite hymns. We believe that is an extra layer of support to the family. When they pass away, our team will go again and give tribute, words of encouragement, and songs for the family. We offer prayers too. We have received lots of compliments, and one family member shared his thoughts about our songs. He said that Once we started singing, the room was filled with hope and comfort in spite of the pain that they were experiencing. That's how it all began.
Perfect. Thank you, Uzi. That example really illustrates our palliative care Bullseye framework, and I won't go into it into too much detail, but the key of this is that the resident and family is at the center and the core of the framework, and around them is layers of the onion or the bullseye that we had created. And so just as an example, the first layer was looking at different common issues, again, identified by residents and families, and examples include symptom and disease management, loss and grief, and really making sure that we meet the holistic needs as illustrated through Uzi's example. So in terms of evaluation, we did conduct evaluation pre and post, primarily through doing surveys and chart reviews. What we really found was that for family members, they reported an increased comfort and support through improved communication, continuity of care, and emotional support provided at the end of life. And with the healthcare team, they also reported an increased comfort and knowledge to provide palliative care. And so it was really about enhancing capacity, but hearing what family members and residents had to say. We also have two quotes illustrating the impact. The first one here is from our medical director, Dr. Mary Jane Schenkel. And I just wanted to focus on at the latter part of the quote, which really was feedback from one of our family members. And what they said was that they felt that this was the single most powerful experience in their life that they had ever experienced. We also have another quote from one of our frontline staff members who said that the program really allowed them to provide the best care possible and address the needs of our residents. So in terms of spread and sustainability, we have scaled this initiative to the other care homes within the foundation that I mentioned at the start of the presentation. The program was also shared through different forums such as external presentations and conferences by the Director of Nursing, and we have sustained it through ongoing education and mentorship by our executive and clinical leaders. So to summarize, we felt that this quote really encapsulated the reason why we embarked on this journey to improve care, and it's from Dame Cicely Saunders. It says, "You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." Thank you.
Thanks, Navjot and Yuzi. That was a pretty smart question that your manager asked you, Yuzi, and it was a great answer you gave, so well done. And I suspect there's big demand for you to be around when people are going through this. But you know, of all the patient experiences, I don't think there's anything more important or more challenging than end of life. And let's face it, we're all going to be there one day. But I think the things that you've done to really personalize this to the individual resident and family is amazing. So well done. And those practical brochures and tools that you developed, I think, are so helpful to ensure that families really know and understand what's going on in the resident as well. So well done. It's a great initiative. So now I would like to introduce our last presenter, Jennifer Brower, Program Manager for the Inner City Health and Wellness Program. And I'll bring her up to speak on her initiative. Jennifer?
Thank you. My name is Jennifer Brower, and I'm honored today to represent our team, the Inner City Health and Wellness Program. The logo you see here on the first slide is for our clinical team, our Addiction Recovery Community Health, our ARCH team. If you asked me 2 years ago, when I started in this program, what this logo meant to me, I would have told you and explained it to you from a provider's perspective. I would have said it's an open door. It's removing barriers and creating easy access for our patients. My perception of this logo has changed significantly throughout the 2 years that I've been with this program. Working with a passionate and dedicated team alongside amazing and resilient patients, I would now tell you this logo represents patients opening their door to us. Breaking down barriers, building relationships, and always keeping the patient at the center of what we do has created an environment that we all feel privileged to work in every day. This is a picture outside of our emergency department at the Royal Alex. We are an inner city hospital located in the heart of Edmonton's inner city. If you ever came to the Royal Alex, you might see a scenario like this quite often. We serve a high number of Edmonton's most vulnerable patients, many with untreated substance use disorders, medical and psychiatric illnesses, and substantial social inequities. Many of the patients who were accessing our hospital were being treated for their medical concerns, but were often being discharged without addressing any contributing factors such as homelessness and poverty. Patients that were admitted to our hospital often were unsuccessful with completing their course of treatment or remaining in hospital for a variety of reasons, but mostly because our rigid system did not allow for them to practice things like harm reduction, and it also did not allow them to really be active participants in their care. So understanding the challenges and recognizing the need for change, and with incredible support from our Royal Alexandra Hospital Foundation, the Inner City Health and Wellness Program was established in 2014. So there were many contributing factors and pieces that helped get our program up and running. We conducted a large survey of patients who had accessed our emergency department for acute chronic substance use and or were unstably housed to get feedback from them, We liaised with many of our community partners and agencies that we often were trying to connect patients to on discharge, sometimes successfully, sometimes unsuccessfully. So we spent a lot of time trying to see how we could build those relationships. And most importantly was consultation from our community advisory group. This is a picture of our community advisory group the day of our official launch at our hospital. The quote underneath the picture you see, "Nothing about us without us," is a quote that you might hear in many different service settings. But for us, it was really important to keep this at the center of what we did. We wanted to build a team and build services and programs within our hospital that our patients would use and that they had input into. So this group contributed to a half-day planning session where we spent a lot of time talking about what needed to be improved at our hospital. Some of the key themes that came through were the increased need for communication, a more holistic approach to what we were doing, and always using best practices for addiction medicine in our hospital. There was also quite a large emphasis on the ongoing need for our community advisory group engagement, and to this day we still meet quarterly and involve them in all of the things that we do. So our solution, our program, the Inner City Health and Wellness Program, has three key arms to it. The first is the clinical consult team, or the ARCH team, which I've already spoke about a little bit. This is a multidisciplinary team in our hospital designed to provide a full complement of support to our patients who are admitted. We have physicians, we have nurse practitioners, addiction counselors, social workers, nurses, and peer support workers. Our peer support workers all have lived experience and often come from a background that relates very much to our patients. And they have been instrumental in helping us to establish credibility with our patient population and breaking down that first barrier of learning to trust. Our research program is quite robust and focuses on many aspects and outcomes of our program. We often make changes and adjust our services in response to patient feedback, mostly obtained through our research team. Finally, we have an education arm where the primary focus of this group is really to work on changing the hearts and minds of our staff through knowledge and support. Culture change was a huge aspect of our work and something we continue to work towards every day. All of our work and services provided is informed by our community advisory group. We don't implement anything without their input. I have many examples of where they have certainly steered us in a clearer direction than I think we maybe were going to start with. Some of those include our managed alcohol program, our immunization program, and our supervised consumption service. In 2016, we did receive permanent funding from Alberta Health Services, which was quite a huge accomplishment, I think, for a grant-funded program. In our first 2 years, we've served over 1,700 unique patients, and that number continues to grow. As our program expands, we are looking to move into the emergency department so we can provide quicker access to those patients in need. We currently still are not able to see a large number of those who access our site. I think one of the most valuable and influential evaluative measurements are all the quotes that we've gotten from our patients through our patient outcome evaluation. This one here I really struck with me. So the quote says, like, they treated me like more than just a number. They treated me like I was a member of their family, a little brother, or somebody they actually cared about, which was big. Arch is the first organization I've dealt with that I felt that kind of care and commitment from. I think that really, quotes like that and patients like this patient are what really help us to continue to move forward sometimes when there are challenges that we may see. In the past year, we have received further funding from the Minister's Opioid Emergency Response Commission to expand our program. In September this year, we will be embedding a second ARCH team in the emergency department at the Royal Alex Hospital so we can have quicker access for our most vulnerable patients. There will also be an ARCH-like service implemented at the PLC in Calgary. I think for myself as a manager, one of the ways that I know we've really done great work is the requests that I get both throughout the province and also throughout the country for information on how we've managed to implement a team like this in an acute care setting. It's been, I think that really speaks to the novelty and the patient-centeredness of our program. Recognized barriers to spreading this work include the need for increased training for all healthcare providers, including physicians in addiction medicine. A large part of our work at the beginning and still is to advocate for better training for patients with substance use disorders so we can care for them appropriately. This program, I think, although you would consider it highly cost effective, raising initial funds to implement similar programs I think would be a bit of a challenge. This is not something that you could do off the side of your desk. This takes a dedicated team and that works very hard to meet the patients where they are in the hospital and try to improve outcomes as best we can. Finally, and I think perhaps the biggest barrier to spread is changing culture, changing perspectives, and embracing a more patient-centered approach for our most vulnerable patients that we see. This is an ongoing advocacy that we do, and I think we are making big headway, but lots of work to do still. Thank you.
Thanks very much, Jennifer. You've done some great work. It's a busy emergency department there, and to have resources like this for your clientele, for the select clients that come in, is really amazing. And I was really pleased to see that you've got permanent funding because this is so meaningful and so useful. So we are now down to our question period. Do we have any questions from the outside audience? We do. All right. Christina's going to.
So our first question is for Ellen with the City Center team. How does the CPP van differ from an ambulance with respect to equipment and supplies?
We do carry most of the same emergency supplies as an ambulance does, but we have a lot of extra things that help us provide a larger scope of care. So we also carry like a suture kit, a urinary catheter kit, and we do carry safe consumption supplies as well for our clients. We have a stretcher, but we mostly use it for if we need to do sutures rather than transporting patients. We don't transport to hospital because we're only one single unit, and if we ended up stuck in the emergency room, we would be of no value to the rest of our clients. So we do call for an ambulance if they need transport to hospital.
And actually the second question follows up on that. Given that you're just one unit, are there any plans to spread or, implement your program elsewhere?
Certainly we've looked at that because we are getting close to capacity now, where we're pretty much busy all the time. There's a couple of things that are coming up that we're looking at. One of them is a respite area in one of the shelters for patients just coming out of hospital, or possibly for end-of-life care as well, which we might be involved in. And certainly we do talk about needing more services in the future just because we are only one team.
Sure. I have questions for everybody here, but the one that I'm going to start with, Jennifer, you talked about having to engage a number of or develop some partnerships to ensure that the needs of your clients are met. What were your biggest challenges with establishing partnerships? Did you find some that were a little more difficult to convince to be a part of this, or talk a little bit about that, could you?
I think our community partnerships, establishing them was not as challenging as maintaining communication streams and ensuring that we had timely communication and follow-up for our patients that were coming into hospital and then subsequently leaving, either being discharged, leaving Emerge, or leaving on their own through their own decisions. So I think mostly it's just, you know, trying to understand all the resources available, and then try to put that into context with the patients and link them with a community provider as best we can. Our goal is always to support patients through hospitalization, but then connect them with a community provider. We don't want anybody leaving our hospital without being connected to either a primary care physician or a community agency that can help support and carry on the care that they've received.
Great, thanks. The other thing that I was impressed about your application was your advisory group, which are community members with lived experience.
Yes.
And I see all the value of having that group together. What are the challenges of meeting with them on a quarterly basis, or engaging them?
I think there's some practical challenges. We don't always get the same turnout, for sure. Yeah. I think the biggest challenge is more for us to take what they give us in terms of the knowledge and the requests and the things that we need to improve on, and then putting it into a practical application for our hospital. I think that's the challenge.
Sure.
We enjoy, you know, we certainly have fun. We meet together, you know, provide a patient honorarium for their work, and so I think the real challenges for us as care providers is to utilize the information and the knowledge that we get from them and put it into practice.
Great, great, thanks. Sir, I was wondering from your work, there must be some negotiation or some work to do in ensuring that everybody, you know, patients and families come to the same conclusion about their choice for treatment. Can you talk a little bit about that and how you resolve those issues?
Yes, it was, so when we started this pathway, we were hoping necessarily, it wasn't quite up front and center, the patient decision aid component. It wasn't even part of the original funding. No, and it was one of those things that, you know, you hope the funders don't necessarily realize when they're reading it. But as soon as we brought the patients to the table and our nursing staff, who were often left to have these conversations themselves, it became very clear very quickly that if this pathway was going to work, we had to get the right patients on the pathway. So it was about uptake as much as keeping them on the pathway. So this was the work with the patient decision aid. And I think I can honestly say that that work around that interactive patient decision aid was one of the most rewarding pieces of this entire project, and it's been one of the most successful. So it's a very interactive tool that is very different from most tools out there. It looks at patients' preferences and values, but it also has a very tailored prognostic piece into it that focuses not just on survival if they go on dialysis versus conservative care, but it's also, will it improve my symptoms? Will it improve my physical function? Will it improve my quality of life? So they get that big picture. Then they can look at their values and say, well, do I have to travel? Can I stay at home? Does it mean I'm going to have to be hospitalized? And at the end of it, you know, we even ask questions like, who's involved in your decision? Are you feeling pressure from anybody? And then they can write it, they can email the results to their family, they can print it off. We have those discussions in clinic. So it helps healthcare providers structure that conversation, and it helps the patient. It's for everybody.
Sure, great, yeah. Tough decisions and hard conversations, but ones that I think would be really worthwhile at the end of the day, really rewarding as well. Navjot, so a really important part of this work is obviously building relationships with your residents and their families. Can you talk a little bit about this framework and the program that really helps you be successful with your initiative?
Yeah, I think the key is really to have ongoing feedback and support from residents and families, and we did that through a different mechanism, primarily talking to them and through the needs assessment that we did in collaboration with the Faculty of Nursing. But I think hearing their voice and determining what is really important to them before jumping to solutions really made us develop a framework and pathway that was sustainable in the long run. And so we do ensure that we are checking and making sure that we are meeting their needs and their holistic needs on an ongoing basis.
Great. So Izzy, were all of your colleagues as enthusiastic about this work? How did everybody come to that same level of engagement and enthusiasm about this end-of-life work?
Actually, if you engage with that and you have positive, effort,
Which
they
you
will
obviously
also
do.
and they will also join with you. I told them, it doesn't matter if you're a good singer or You know, if you are out of tune, it doesn't matter.
Sure.
As long as you care for your client or residents, that's the most important thing there. Yeah.
Yeah, there were some lovely comments, weren't there, that you received from patients. It's obviously made a big difference. So, how are we doing for time? Are we under time? This has been really amazing, and I've really been pleased to host this presentation, this webcast. If you have ongoing questions, we ask you to send them into the website, or if questions arise after you've sort of thought about these presentations, please feel free to send those questions to our website at info@hqca.ca, and we will work with our presenters to get responses to that. Thank you again to our presenters. You've just done such a fabulous job. We really appreciate the time that you've taken out of your workday to come and do your presentation here, and I know that the audience have enjoyed it. And I suspect you've inspired others to really think about how you can really benefit or improve the patient experience in the service and the care that we provide. I'd like to thank everyone actually for your interest in the Patient Experience Awards program, and look forward to many more submissions about improving the patient experience next year. And if you don't already receive it, please visit our website at www.hqca.ca to sign up for our newsletter, and you'll get information about next year's awards, so please stay tuned for that. This live stream will be posted on the HQCA's YouTube channel shortly, and an overview about each program discussed today can be found at our website as well. So with that, I say thank you very much, and we'll sign off. Thank you.